So we agreed that monitoring and the supervision is important. And now we talk about how we do this and how we shall try to achieve more results after the supervision, so that it's not just, for the sake of supervision or monitoring. And therefore, we need to think what kind of supervision or monitoring we will take. There are different approaches to supervision, and we will talk about it. This is the definition of supervision, and also we need to see and understand the different types of communication and leadership skills necessary to be a supportive supervisor. Now, what is supervision? It is a process of connected events, and it's not a one-time event. It implies guiding, helping, encouraging staff to improve their performance in the long-term period so that they meet the defined standards of their organization. Supportive supervision also means helping staff meet the defined standards of their organization and the service delivery standards or management standards define how the work shall be done. Types of supervision: controlling supervision and supportive supervision. And we all know that our supervision is the supportive supervision and not the controlling one, because it shows on the graph very well how they are different. Controlling supervision means that we came somewhere, we looked at things, found mistakes, we noticed that it's bad, then we write our conclusion or opinion, and that's it. But it's not good for the TB. Our supervision shall be regular, continuous, and we have to achieve the goals and etc. Therefore, all the data and all the results that we have, we need to look at it together, and they need to understand that they are important for the program and everybody involved in the program. Their support will be organized at the central level, and that all their questions will be answered and all barriers will be eliminated as much as possible. So controlling supervision is not for us. What about supporting supervision? It is aimed at solving the problems, empowering staff to perform their roles, building training skills. It is very important, and participatory decision making when you ask them then what they think about this or that. So it should be some sort of a conversation with this medical staff, the doctors and nurses. A process of helping staff to continuously improve their own work performance. And of course, it should be all respectful, non-authoritarian way, and so we have to support all these people. Now let's see what's the difference between the controlling and supportive supervision. Controlling tends to focus on administrative issues, providing solutions. It's punitive and critical, reactive, and doesn't look for root causes, focuses on finding faults with individuals. It's sporadic. It's one-way communication, doesn't empower staff to engage in problem resolution, little feedback, little to no training, I would say no training, and solely supervisor's assessment, where the supervisor doesn't ask whether they agree with such an assessment. And supportive supervision is 180 degrees different. It is not administrative, it's beyond administrative issues, and it is, solving problems jointly, and we facilitate performance improvement and shared responsibility. It is proactive, which aims at preventing performance issues. It focuses on work processes and systems and improving relationships. And they should be awaiting us and glad to see us. It took me 3 years so that my team is not called the commission, like the vision or something. We're not the commission. We are the central team. We came to you. We want to see how the program works in your region or in your district. Tell us what your problems are. We'll help you. The most remote areas, they are happy to see us, and they say, oh, at least someone is interested in us. And when we tell them that 4 times a year coordinators will visit you, tell us what the problems are, etc., they are happy to see us, and we visit them, every 6 months or once a year, and they are happy to see these people coming from the central level. And we jointly discuss all the topics that they want to know about, and they tell us, what are the impediments. It can be the chief doctor, etc. And we, of course, try to resolve the problems locally. Well, if it is something bigger, then it can be resolved at the level of the program. Well, two-way communication is absolutely crucial. We need to have the feedback on the job training. I like this word of mini training. It's a quality thing, because it's like 101 working, like the question and the answer, question, answer, and it's much better when 15 or 20 people sit in one room and listen to a presentation. So this mini training is required. It's a very good thing. If they don't know how they need to evaluate themselves, they will teach them, do it, and we agree with them. So we assess, every institution, and after each supervision, they sign off the report, and right there we explain to them why why it is this type of assessment today, and if not, then if they sign it off, then it means that this two-way communication and the feedback works. Now, why do we need the supportive supervision? I don't think we need to stop on it. Just briefly, it is identification and resolution of issues. It's revision of guidelines, SOPs, updates. It's a resolution of conflicts. It's encouragement. It's building capacity. It's also the motivation. It's empathy. It's support, which they like a lot. And then we decide when we come next time and what they need to correct by that time, by our arrival. So national, regional, district, maybe in other regions is different, but this is the best option, we think, when it's the district, regional, and national levels of supervision. Now, steps to conduct supportive supervision. You said that you were getting ready. You said that you take the reports that they sent you, the lab data, and you go prepared when you know what you need to look at and compare. So all of that is done before the supervision. Then the process itself during the supervision, what we do, and what we need to think after the supervision. So let's go and look at all steps. Supportive supervision. Before, what we do? Well, first of all, we need to form a group. a team of supervisors, and of course it shall be, a very well prepared team, well trained, so they know the guidance, so that they have answers to questions, so that they can explain well. If there are previous reports, you study them so that you know what to expect there and what to compare to what. You need to prepare the questions, plans, schedule communications, guidelines, SOPs, that they know, which also contains all the steps: stationary, patient, client complaints. And one of the important points is financing. Well, no matter what, without financing or without funding, we will not be able to do the supervision. So your supervision is funded through the Global Fund, right? And in Armenia, is it the same? Yes, Global Fund too. Ukraine? Global Fund and the USAID. Two donors, all right. As far as I know, in Azerbaijan, Alexander visited Azerbaijan. They are preparing the grant proposal currently to, so far they don't have the Global Fund support, and they say this is exactly why they don't have supervision. Now, during the supervision, we meet the manager of the facility, we resolve problems together, we look at the reports, we observe the services, interviews are very important. Would you please ask her to keep microphone closer to her mouth? So, thank you. So we always talk to the doctors about, and also talk to nurses. And when I talk to the nurse, the doctor listens to us and vice versa, and then would bring in the patient and talk to the patient too. And if the patient said something wrong, I would note it, but after the patient would leave the room, I would ask, why is it like this and not like that? So when we started monitoring, we worked only on sensitive TB and the treatments, as she says, and the standard treatment, and the treatment was sort of independent, like pulmonologists can now independently prescribe things. And everybody was saying that it's impossible to treat or cure TB without injections, but we were trying to prove that it is possible, and isoniazid, rifampicin, that they are, strong medications. And in one of our conversations, a very nice doctor, a very nice nurse. So we invite the patient and we ask the patient, are you happy? Are all services free? And says, yes. And do you feel well? Yes. Do you pay anything anywhere? I just buy streptomycin. And then I said, how many? And he says, well, I had 30 shots and 30 more remain. And the patient leaves. And then I like confessions. The physiatrist said, "What, dear Marina, I'm almost 80, says the doctor. I am in physiatry for so many years, but I can't even imagine how we can treat the TB patient without injections." So this was a super confession, because the doctor worked for such a long time, and then some young people came and they gave this some sort of strategy and they wanted to be implemented in Georgia, like that. So stage by stage, step by step. And also we had the nurse who said that because she works in this facility, she is afraid of getting this disease, and that every spring and fall she takes the isoniazid not to get the sickness. Well, yes, it happens, and I talked to her for a very long time. I was trying to convince her not to take this medicine, and she looked at me and said, if I don't take this medicine, then I will definitely catch this disease. Yes, of course, there were different moments during the supervision. And why do I like interviewing patients? Because sometimes they say things that we wouldn't hear otherwise. And they would say that, I have a child, and when I left the prison, I had the TB, and I have my plate, I have my mug, but yet they would sleep in the same room. The father would hug the child, kiss the child, so they did never know what are the ways of contracting or transferring this. So we need to teach them. The child's TB always shows that the program doesn't work well. So we identified, we had the case, we have 45 cases of child TB, and it's just 45. And if we don't have TCO pediatricians everywhere, we have one remaining in the region, because from districts they're referred to the regional, because they have basically nothing to do and they need to requalify. And we have one wonderful unit that the ministry built for 20 beds, and it's empty. And it was quite helpful during COVID, because we could use it for COVID patients. Well, of course, it's good that we don't have meningitis or child tuberculosis, but the physiatrists, pediatricians, they suffered, therefore they are only at the regional level. Now, what do we need to think about afterwards? We need to share copies of findings and action plans. So they need to have our feedback, and in the protocols we have the whole list of findings. In our report, what recommendations were given and what were the criteria used for assessment of this or that entity, and they are signed off. Now, we also provide ongoing indirect supervision. We communicate findings to all thematic units and stakeholders. We collect it at the central level. So we get together on a quarterly basis, and then all stakeholders attend it. And there we discuss all the issues. They are different because regions are different. Well, somewhere it's better, somewhere the conditions are worse. And we try to help at the central level. If not, then we would, address the global fund or the ministry, but we try to eliminate the reasons that are an impediment to work. Well, of course, we provide for ongoing and indirect supervision. We, of course, plan the follow-up visits, and especially if issues persist. And but you see, we may resolve some problems during one visit, and then for the next visit we could find something else. And if we're happy to see that everything's great, So again, trust but check. Now, the benefits of the supportive supervision, let's go through it. It improves TB service provider skills, yes, it does. It builds partnerships and provides the on-job training, well, it definitely does, because it's a supportive supervision. And we heard about this, deficiencies of the controlling supervision. Now, supportive supervision increases accountability, helps staff see how their performance has improved, improves the quality of data being received from different levels of the program. It encourages data use, etc. Now, what are the challenges related to supportive supervision? We've underlined those. It can be time-consuming due to the planning process. It can be funding. It can take a lot of time because of planning. Our countries mentioned it. Developing schedule could be difficult because of conflicting events. Action plans and timelines may not be implemented as agreed, since supportive supervision is not punitive. And this is why the lead doctor puts it on the table and said that, yeah, okay, I got it. If I won, I will look into it and do it. If not, then I don't. Yeah, so we do have all these difficulties just as you do. Let's go on. Self-assessment. The supervisor should give the TB service provider an opportunity to assess themselves, assess the provider fairly, give feedback, before leaving the facility, allow the TB service provider to comment on the assessment. I will speak about it when I will speak in 2 slides about how we do it in our country. I will not add here so that I do not repeat myself. Tips on providing feedback. Supervisor should work with healthcare facility as one team. We've mentioned it too, and we all agreed to it. And if we need to comment on something, then we won't do it as in the case of controlling supervision. We'll do it differently. Yeah, encourage. Yes, we'll tell them that, yeah, you correctly see the problem and you made the relevant steps. So we don't tell them that, oh, what is this nightmare? What have you done? How could you do that? You shouldn't tell them you made a mistake or something. We just say that, yes, we identify the problem. Let's find solutions. Let's do something to improve the case. So this is the feedback. Leadership skills. I think I've touched upon that, plus we're limited in time. We, of course, have these skills. Well, in Ukraine, they said that there are people who are not sufficiently prepared for supervision. And we need to be able to speak, to tell, narrate. It's not that we're just making comments or reprimanding something. We have to talk to people. Coaching, of course, for every supervision. Every supervision implies coaching and, of course, support and advice. Well, I will not speak separately and will not explain to you what's telling, what's coaching, supporting, or delegating, because in your questions and during our discussion, we've touched upon it. And we said that it's important to tell, to listen. We need to know how to speak with people, how to coach them, etc. Examples of effective communication skills. Well, active listening, body language, paraphrasing, clarification, questioning. We all know it and we do it. We spoke about it too. Now let's look at the barriers. Insufficient time is a barrier. Absence of clear job descriptions, lack of transparency, failure to take inputs or give feedback, complexity of message or communication, frame of reference, and inconsistency between words and the action. Well, yes, it is in our hands, and we shall try to work on those. Well, we won't have any role play because we are very much limited in time, and also we're reported in our countries. So just let me tell you briefly how we do supervision and what are our advantages. I like the definition of supervision. It is the primary, regular, continuous, planned process of oversight of the effectiveness of the major elements of TB strategy. In Georgia, we do supervision since 2003, and I wanted to note that we had the WHO consultant, 𝗵𝗲𝗶𝗿𝗲, maybe you heard of him. We discussed, we developed it all together back in 2003, first protocols, etc. We had 5 or 6 pages. It is now, initially it was 2 pages, because we didn't have treatment for resistant forms, we didn't have preventive treatment of TB, so things improved gradually and therefore protocols change. Now, the purpose of supervision: data quality assessment and validation for every case, quality of implementation of the national TB guidelines. This is very important. Quality assessment, implementation is important on every stage. Quality assessment of key indicators of TB control and activities on site locally, providing methodological support and advice, prompt detection of existing errors and their timely elimination, and the last one is feedback and coordination. Principles of supervision. Supervision is carried out in entire country from the very first year. As of the year we've started with the supervision, including the penitentiary system. It includes all TB units in the civilian and prison sectors. It is implemented in the format as recommended by the WHO, present at the central and regional levels. Central supervision is conducted twice a year. And 2 quarters, first and second, and then third and fourth, are studied together. And regional supervision is being conducted on a quarterly basis. So they visit the facilities in the region 4 times a year. So these are the levels of supervision scheme, things that I was telling you. And Naira had a question. As a national center, we have the program management and coordination department, and I am the head of that department. So we have support or supervision from 2004 through the Global Fund. Also, we have central monitoring level. We have regional coordinators, 9 of them, plus penitentiary system. And you see here that the central group monitors regional groups, and regional coordinators monitor all the services and the facilities that they have in corresponding regions. And the central monitoring monitors all the coordinators, etc. And these are primary healthcare facilities, then in the end, who help us with detection of cases, and also help us, to identify the most convenient geographically convenient places for the patients. And of course, central monitoring, covers everything, this cabinets, the primary healthcare, the TB service units, etc., from A to Z, and it doesn't matter where the patient gets treatment in 𝗵𝗲𝗄𝗃 or somewhere in the high mountains. We look at it and we monitor it anyhow. And if we estimate 9 regions plus 𝗵𝗲𝗄𝗃, there's 2 villages, it's like 20. So minimum 40 villages or settlements, maybe she means, that we look at. And if required, we look at more. Well, in some villages, there can be, some extraordinary things happening. We had a case like 3 people all of a sudden getting sick with it. And so we went there and we found drug users, like a bunch of drug users who got sick. So we went there, we talked to the primary healthcare doctor who was overseeing the treatment. So it all worked well. So yeah, we do have plans, but something extraordinary, something unplanned may happen, and therefore we can change and, somehow be flexible, so to say, and regulate things on an as-needed basis. Do you have any questions about that? No, all right. Scope of supervision. Well, it is quite limited, and it works in different directions, like diagnostic, treatment, and preventive measures, then recording and reporting system. At the central level, it is done by me. I deal with that. Lab management, it's clear it's about the lab. And TB drug management, it is drugstores, so the heads of the drugstores, the pharmacies. Now, diagnostic, treatment, and preventive measures and reporting. What do we look at there? Number of presumptive TB cases, and we do it the same, the central or regional level. It's just we look at 2 quarters together. They look at every quarter. Number of active TB cases, signing definitions. It is the painful matter always. Somebody somewhere still does it wrongly. Treatment regimens, case management, medical records management, contact investigation, chemoprophylaxis, R&R forms management, infection control, interviews with medical staff, and patient education adherence. Well, if something works well, then we don't look deeper, and if we identify the problem, then we try to study it. Now, lab management looks at the qualification level of lab assistants, laboratorian workload index, quality control, sputum transportation, interrupted supply of lab materials, reagents, and referral forms, and sending and transportation. TB drug management, everybody has their own protocols. I have my own, lab has their own protocol, as well as the TB drug management has their own protocol. Drug storage conditions, uninterrupted supply of drugs, documented tracking of drug utilization, stock management, consistency of supply requests. Supply requested, then it's sent, and then it checked locally whether it was correctly requested, what was used, and what remained. Sources of data collection, they are the same from all levels. These are our journals, so logs. It's for presumptive cases, confirmed cases, treatment of resistant TB cases, TB contacts registry that was changed and then complemented, laboratory tests and referral forms. We call this journal or the forms, the referral forms 05. Daily log of drugs, quarterly registration forms, like TB 08, and individual forms for recording TB cases, the most important for us. I spoke about it yesterday. It's 1012 that is very helpful. Medical cards for treatment of sensitive resistant TB, DOT monitoring forms of recording resistant TB cases. So it's all things that we need, and everybody knows that we pick a patient and we look through all of it. Now I want to share with you what kind of protocols we have. So that everything is correct, accurate, and precise. So if we look at the presumptive cases, we take it for the quarter, although I look at 2 quarters. we first look at the quarterly data. If we want to compare quarterly data, then of course I can take, like first quarter. And these are firstly new cases, and then confirmed cases of TB, and of course the children under 5, adults, and altogether total. So we have in general for treated cases, active forms of TB, and confirmed. So this is what we want from these journals. The only thing we want for these data to be precise, new cases, confirmed, because they may say this is the case, or no, that was the case, etc. No, we don't care about that. We need precise data. Now, contact investigation, also quarterly, total number of contacts, number of infected cases, children and adults, number of cases in preventive treatment, treatment regimens, and number of confirmed TB cases, children and adults, and also how the preventive treatment was completed, and because of the 𝗫𝗫𝗲, the prophylaxis works, and also the preventive treatment for contacts. Now, total number of registered TB cases quarterly. We want to exactly and precisely know, and we have the schedule, but we can't see it here. Okay, we want to know the pulmonary case. Yeah, the exact number of pulmonary cases clinically diagnosed, extrapulmonary confirmed, extrapulmonary clinically diagnosed case of TB. So, and we look there at new, recurrent, previously treated, or unknown. In all of these cases, we look at these things. And the confirmed, it might be cytology or something else. Well, for extrapulmonary clinically diagnosed cases, there are always questions whether it's TB or not. We always have disagreements with doctors on that. The good thing is that we have very few cases like that. And if somebody has the bone marrow TB or urinary tract TB or lymphatic nodes, etc., then they have to be referred to Tbilisi, because only we here in the capital city have those professionals. We also look at the HIV, number of TB patients tested for HIV, confirmed cases of co-infection, and enrolled in treatment or not. Yes, this is also the 100% coverage. Outcomes of sensitive forms treatment that started treatment 12 months ago. These are confirmed pulmonary cases, pulmonary clinically diagnosed cases. Will it be news or relapsed? And we have this data on district, regional, and central levels. Why do I underline it? Because Andrei likes it, sort of that we have our database if we need to recalculate something. And he always said, so if you have it ready, then let's do it. We have lots of details there in the database. So very few countries actually collect information at district levels. What 𝗫-𝗲𝗄 Anushka was saying. Yeah, and quarterly forms. Now as to resistant cases, well, with that's like interim results, confirmed cases who started treatment, sputum conversion, those who died in the course of treatment, lots to follow up. Here we need to change something because it's like about less than 9 months or 6 months, and the sputum results may be different. And it was the journal and with forms O2. Now, assessment of registration and treatment journals. And when we look at these logs, then we discuss everything with the doctors. Now, patient information, appropriateness of the definition assignment, the right treatment regimen, laboratory monitoring, cross-checking for the journals, appropriateness of treatment outcome definitions. This data is entered into the database timely, quarterly reconciliation of journals with the database. So we have permanent communication. When we're in the field visit, if something's wrong, we immediately call, and Mamuka looks at the data in 𝗵𝗵𝗿 and say, we look at that in Batumi. And if there are inconsistencies, then of course we try to eliminate those. Now, transfer of the data on cohort, and again, reconciliation. Reconciliation is very important. Every manager on a quarterly basis, despite supervisions, they do reconcile, they do check it versus 03, the database, and it is done by the database manager. We have one such manager in the region through the Global Fund. So they look at the data together with Mamuka. Yes, and when we look at the passport data, we check whether it's right, whether names, surnames are written correctly, their personal numbers, etc., etc. So we had cases when we look at 3 different records, and you'd have an impression that there's 3 different people. And now they reconcile TB04 and TB03 themselves. So, but before that, we didn't even know, was it one patient or three several? Because in the lab journal it was says negative, and then TB03 would say it's positive, and etc. So where do we look? And only their comparison and reconciliation allows for changing it all, so that this one patient or somebody else, and you really don't know, you wouldn't know which form was correct. And if it is so, then we need the primary document. So the sputum test, it's not done deliberately, and people will say, well, yes, I was supposed to enter this data, but somebody called and I forgot, or misread or miswrote or something like that.
That those who are dealing with TB3, they know how important it is to be very careful, very accurate. Of course, selectively, and if we don't come up with some common opinion, so we have to make the check correctness of diagnosis, availability of laboratory test results, quality of documentation. So previously, well, sometimes it's that they do not have the log, but then I check, but then I know that they have already started doing it. So, well, what I want to say is that sometimes it is, yes, good, sometimes no good, but sometimes it is partially good. So in that case, we tried not to say that it is bad. Assessment of a facility. Every facility after every supervision is evaluated, is assessed. So there is a special box in the protocol where we put in our assessment. We also have recommendations for solving the detected problem, and also we write recommendations and then facility assessment. So if we have no recommendations, it means that the assessment is successful. If there were some mistakes, we made recommendations, then they agree that which is good, but sometimes we have the, well, are just satisfactory. We don't want to write that some of the facilities are non-satisfactory, but so satisfactory facilities say the number is reducing every year. So what are the criteria of evaluation? I've shown you our criteria. I asked questions about trainings, etc. So what are the criteria that we have? It's according to the logs. Okay, so presumed cases, contact, log book, treatment log of resistant TB, recording treatment form. So whatever we have already seen, we tick the boxes in our form. Then, for example, review medical records, presence of diagnostic errors. Well, I've talked about that there could be some diagnostic mistakes like hyperdiagnostics, clinical cases, etc. And then we start checking logs. Now, well, discussion of special cases, they prepare them themselves if there are cases. So if it is urgent, they call us, and if not, they prepare them when they know that we're coming, and we all together discuss those cases. A question: the monitoring group or supervising group, how do they determine diagnostic mistake? If this is a clinically diagnosed case, the doctor thinks it's TB, but the supervision group thinks that this is overdiagnostic. So, well, it's difficult to answer that because not all the cases should be excluded. Because if there is something, the TB specialist has the right to diagnose a clinical TB, clinically or based on X-ray. The only thing is that there is no laboratory confirmation. And very often at a certain stage, we receive this confirmation, or we don't receive, and at a certain stage, the treatment is terminated. So we check the cases that were treated. So first of all, the first X-ray, second X-ray, third X-ray. So first is okay, there are some signs on X-ray on the first, and nobody can say, well, when there is infiltration, nobody can say whether this is TB or pneumonia. But if by the second month there is nothing, no clinical complaints, nothing, and there is okay, so the question is, how do we prove that this was TB case? So what are the recommendations we give in that case? So we say that if you have a patient like that, in our center, we have consiliums for resistant for TB forms and for clinical. And there is one day when all the clinical cases from all the regions should be either approved or rejected, etc. So we look at this very carefully. Of course, we respect clinicians. I am a clinician myself, and I cannot agree with everybody that there should be some other signs. Well, sometimes there are no other signs. So we always advise that if we start treatment of TB 2 weeks later, nothing will happen. So let's start with some drugs, and if there is no result, and we keep on observing. So if the result is good, what does it mean? So there are no complaints, there is a weight gain. So it's not necessary that after every treated case, there is no sign left behind the TB. Of course not. So we solve these issues on site, and if not, we request them to submit all the things that you the continuum central level. And this service works very well. So what works in Tbilisi? Tbilisi, especially for such patients, we have a four-day code, which is free. So such patients are sent to Tbilisi for confirmation of TB diagnosis on Monday or Tuesday. So it all costs money. So we have to provide all the additional examinations like bronchoscopy and others. So if these 4-day they are inpatient diagnostic codes, and this is free for the patients. Everything is done on the level of centers. If the patient refuses, then this becomes paid. So it's up to them. So we are doing our best to avoid hyperdiagnostic and even worse, hypo-diagnostic. So hyper and hypo. So did I answer your question? So okay. So these are the evaluation criteria for my part. Also, evaluation criteria for the laboratory component. So the data that I listed, so how the laboratory part is evaluated. This is lab logbook, referral forms, statistical forms, a reef test, quality of lab monitoring documentation, etc. So the evaluation for labs is done separately. Also, drug management and our representative also looks at following criteria like availability of the facility, daily temperature and humidity monitoring, uninterrupted supply of drugs, separate storage of expired medication, documented tracking, journals, numbered pages, numbering of pages, information on each drug. You know, these is a standard WHO log. So daily reporting of medication, actual quantities of drugs available with the documented quantity. So there are 3 evaluations of everything was great. So we, but just for them actually to somehow explain to them that they have missed something, they are happy actually. And so we keep on doing that. So indicators. Then we have detection rate, TB confirmation rate, drug resistance surveillance, conversion rate, treatment rate. So I'm not listing everything, but so what's next? So one cycle is completed. The standard protocol is done after every supervision, but the important thing is that how we use them. After each monitoring, the protocols are passed to the central level, are analyzed, processed statistically, and I always have my electronic database. And this database is based on protocol. All the data we have in the protocol is entered there, and all the 67 facilities are listed, all the collected vertically and horizontally. It's a huge database. So to print it out, you need 8 A4 format papers. So that is why we do it. So electronic database is done, and the results are summarized on central level. It is so it is done for 20, it has been done for 20 years. We're not saying that it's super efficient. We're just saying we're going to work in that region, this region, etc. We work there, not supervise. So structural analysis of data makes it possible to objectively evaluate the situation in the country. It is very important the epidemiological situation in the country, effectiveness of activities carried out as part of the national TB program, as existing problem, solutions, activities aimed at improvement of TB program management, compliance with TB guidelines. So what I said, as I mentioned at this meeting, we have external consultants, global fund representatives, and some people, so maybe epidemiologists, maybe some ministerial department. So necessity to update the supervision component. Yes, we are having problem. The WHO standards for definitions, reporting, record keeping, and treatment, they are regularly updated. Improving internal quality assurance systems at the facility level is a critical task. Support of the implementation of the program electronic TB management system, data validation, and support the federal transition from paper-based to fully electronic reporting. Challenges. So sustainability of the supervision component depends entirely on global funding. The status of regional coordination applies to the global fund project. Sustainable TB program monitoring structures at the regional level are not defined. The observations of the monitoring regarding the quality of services is advisory. It is advisable to increase the involvement of medical facility managers in TB issues. Okay, thank you for your attention.